I think that staying calm, and Kelly Wilson talks about in the ACT literature, that your reactions to what's going on is what you want to model their internal dialogue to be about themselves and the situation. So when I'm calm and just like, okay, this breaking it down, that's how you want them to model their internal thoughts instead of just going to the catastrophizing.
Hi, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I'm your production editor, Grace Pratt, and I'm joined by three of my co-hosts today. We are going to finally follow up part 2 of a conversation from a few months ago that we teased we would be revisiting, and then just so many good things popped up. We had to take a minute to get back to it. So we're going to be extending our conversation about couples in integrated care. And if you haven't listened to that part 1, I think you should go back and check it and then pop back over to us here. But first, we're going to start the way that we always do with our co-host introductions. So my icebreaker question for the week is, what is something new that you've been learning lately? A couple of things kind of brought this to mind. First, it's graduation season and residency. And, we always hope that we're producing lifelong learners and that we continue to grow. And, this is the end of only the beginning of their formal education, and they can go on. And I hope that's true for all of us, that we continue learning, whether personally or professionally or otherwise. So I'm curious to hear what you've been learning lately. So going around the circle from me to my left on Zoom, I have Neftali Serrano.
Hey, everybody. Great to see you all. I missed you guys last month for our last podcast. So happy to see you all again this month. All right. So what have I been learning lately? Oh, so first, I'm the CEO here at the Collaborative Family Healthcare Association. I'm super excited about the conversation today. So I was like, I wanted to jump right in. But so learning lately, I wish it was a sort of thing related to my field, but it's not. I am learning on the sort of meta process level what it takes to implement a new data system. We are at CFHA, we're transitioning from a data system for our members and all that to a more robust system that integrates with all sorts of different tools that we use to reduce duplicative work. So I'm learning about that tool and all the related tools. But what I'm really learning about is how people engage change and processes, especially with technology, how difficult that is. This is sort of like an EHR transition for those of you out there who have gone through one of that. And our go live is on Monday from when we're recording this podcast, so just a few days away. And there's been so much anxiety, so much stress, so much like, are we going to get there? Did we make the right decision? So much of that I'm learning about and learning about how that affects teams and managing. Now we're in a good place, I think. We'll see what happens. But that's what's been on my brain for probably the last 2 months.
I'm glad that you equated it to an EHR change, because that I have experience with, and I for sure know the huge undertaking that is. So, yeah, good luck on that. And thank you for sharing that with us.
Yeah. And also for those of you on YouTube who are seeing this, I don't normally wear jerseys to work, but today I'm representing Colombia. That's playing in Copa America. For those of you who are soccer fans, the Nations League tournament for the Americas.
Love it. Next around, we have Jen Thomas.
Hi there. Okay, Jen Thomas, family medicine, addiction medicine, Morris Hospital in Morris, Illinois, and co-medical director now at CFHA. So that's my obvious answer of what I've been learning how to do that and be that and lean into that and have, the confidence and authority to, be that thing. But on the goofy level, I'm learning Snapchat. My third daughter just got Snapchat, and I was like, I need to be monitoring what she's doing. So that's the goofy non-work related thing, is I'm just starting to play around with that and feeling very old and seasoned when my older daughter is like, you don't have to send a screenshot, Mom. You just send the, I'm like, I don't know, but it's kind of funny to play around with the filters. So yes, that's my, professional and just goofy learning, both things.
I love it. Way to be involved, Mom. That's a good way to go.
Trying. I don't know. Maybe good enough.
Then we also are joined by Bridget Beachy.
My name is Bridget Beachy, and I'm a BHC leader, now kind of doing more of a suit role. So that's been interesting, which that might go a little bit into the learning something new. And then I would say before the icebreaker question, for something new, I've dedicated myself to learning Spanish. So I'm on like 380 straight days on Duolingo. So
Wow.
that's going good. So it's not new. And I had tried to learn about 10 years ago, right when I moved to Yakima Valley, and then life happened. And so then I resolved 380 days ago to stop making excuses. And that's where I am with that. And then same thing with a little bit more of the, executive leadership. That's been going on 2 years in September. So both of those, they're not new, but constantly new challenges, and definitely in that learning phase of, it's one of those things that you're like, in 5 years, I'll be looking at this and be like, oh, well, this was, it's no big deal. But right now it's hard. I'm sure it'll always be hard, but at least I'll know some things at that point in a few years. So I'm looking forward to some clarity at some point.
Yeah, it's nice when you get to the point in a role where you're not doing things for the first time again, and you at least can look back with some experience. Yeah.
Yeah, although I can pretty much guarantee you, Bridget, that you never really get to a place of complete comfort.
Right. At least being at like an 80 or 70 instead of like a 30.
Yeah, exactly. Yeah.
And we're missing Monica Harrison today, but I am Grace Pratt. Like I said, I'm the production editor of the podcast, but I am a behavioral medicine faculty at Integra's Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma. And I'm learning something that kind of spans the personal and professional right now. I have been doing a lot of work the last several years on understanding a lot more about trauma and somatic experiences of trauma and chronic stress and resilience and how we work through that in our minds and our bodies. And I was looking for more ways to expand out kind of this expression and feeling through regulation and attempts at, what we can do to regulate. And I found this course that is about art therapy and expressive art therapies and the science of trauma and dysregulation and re-regulation. So I'm sort of in tandem learning the expressive art therapies part of it for trauma treatment, which is really excited to thinking about how I can incorporate that into some of my clinical work and our residency education. But then also just art itself. You don't have to be a good artist to do the therapy because it's more about the process than about the product. But I've always, always, always loved watercolor and wanted to be good at watercolor, but have never been good at watercolor. So as I'm learning, I'm also practicing brush lettering and practicing making splotches and just enjoying the paint on the paper. So that's been really fun. Let's see. So now, before we move into our main conversation, I think we probably have a bit of news and notes. I know I for sure have one. I'll share first, if you don't mind, Naftali. Deepu and I are continuing to move through our Founders series, our Coming of Age series of special episodes of the podcast. We have a few more that are in the final stages of editing and about ready to be released. We have several more that have been recorded, and we are chugging away on that project. So the first episode has been out for a minute, and we've had fantastic feedback on it. The next should be out before even this episode drops, and then more coming right behind it. So I hope that people are listening in. I hope that you're enjoying kind of going back into that history with us as much as Deepu and I are. And those are going to be coming out at a steady clip between now and the conference in the fall.
And for other news and notes, first of all, you definitely go hear those special sessions. They're fantastic. Grace mentioned the conference in the fall. If you're a new listener, you're like, what conference? What conference is that? We have an annual in-person conference that we have in the fall every year. And this year it's in beautiful San Antonio. It's right on the Riverwalk, some Marriott, really nice hotel, real nice situation. As Grace mentioned, it's going to be a little bit of a special conference for us because we're celebrating our 30th year of gathering as a community. And we're going to be doing some celebratory things, especially on that first night of the conference, the Thursday. So it's like a Thursday, Friday, Saturday type conference situation. A lot of people do stay. They might come a little early, maybe Wednesday, maybe stay over Sunday just to enjoy the area and just make the best of it. If you want more information, just go to integratedcareconference.com. And if you want to know who's going to benefit the most from this kind of conference, it's pretty much any member of the care team. So if you're thinking, hey, we need to get our team together and sort of level set our team in terms of how other teams around the country are doing, this is the place to do it, right? I often tell people, like, if you're struggling with convincing your folks how important integrated care is or why certain things you're trying to get accomplished are important, just come to the conference, because the community will teach your teams, yeah, this is what we're all doing. This is how we're doing it. So physicians, nurse practitioners, social workers, MFTs, psychologists. We even have a smattering of clinical pharmacists and folks in other capacities, care managers, psychiatry. All these folks are welcome to come. So again, integratedcareconference.com. The other announcement is that actually this is a super cool thing. So we really care about the healthcare workforce, and we care specifically that the healthcare workforce is coming into the workforce with a team orientation. And we know that's important because so much of the work that we do at CFHA is sort of retraining teammates to be good teammates. So we help physicians work better together with their mental health colleagues and with other members of the care team, their care managers and their consulting psychiatrists, et cetera. And we realized that this retraining, it'd be a lot better if people came in with a certain orientation before we had to retrain them right after all of their training in grad school and medical school. So we really feel passionate that getting even deeper up the workforce pipeline might be a good thing to do. So we've created a membership for juniors and seniors in high school and undergrads. So up till now, the only way you could be a member of CFHA is if you were a professional. You already were either in training as a student, med student or graduate student in behavioral health and up. But we want to get even further up that pipeline. So if you're a junior and senior in high school, or more likely if you are listening and know one that has an interest in healthcare, obviously they don't know yet what they're going to do, but if they have an interest in healthcare and are also looking for maybe something to put on their CV, resume, very important for like college applications, things like that. If you're a junior in high school, this is an opportunity now to do that. So that membership is called a pre-professional membership. It is completely free and is a way for you to interact with and just understand the profession at large. We're going to be putting together at least 1 or 2 events in the year specific to this group. So you can check that out at our main website, cfha.net. And just in the menu, if you look under the memberships, the pre-professional membership will be right there. So exciting. It's something new for us. We're going to be learning from it as well. But hopefully we have a way of continuing to spread the good word that we take better care of people in teams. So that's what we have for today.
That is really exciting and a really innovative idea, I think. I haven't seen from my other organizations that I've been a part of. And so it's exciting to think about where that will go. Well, I want to shift us into our main conversation for today. So we were talking about 3 months ago about couples treatment and integrated care, or just couples in integrated care. And we stayed pretty high level for most of the conversation. We talked about organizational challenges. We talked about documentation and ethics. We talked about even understanding why integrated care and couples could go together. We talked about saying yes and being open instead of saying no when things come up. And so I think we should start the conversation assuming that we just totally convinced all of our listeners that, yes, of course, we should be treating couples in integrated care. So we're going to start there because that was a lot of our conversation. But what we got to in the very end was to start to talk about the need to have just a little bit of information on content, a little bit of information on what are those clinical topics that are likely to come up? What are the strategies that we might need to use when we're actually treating a couple. Say they've come in, we've knocked down all the organizational challenges, everyone's sold, pretend that money and documentation and all of that is not a problem. So now what do we do? And so I want to kind of open up broadly there. We use the metaphor that I like to use a lot of just placing one brick. And we had come up with a few different sort of topical areas that come up a lot in couples. But let's start there as we're kind of building the groundwork for this conversation. What does come up? What does seem to be some pretty specific couple related challenges that we might be seeing in an integrated care setting?
Well, I'll jump in and say, even before that point, one of the things that I'm doing as a clinician, because a lot of times, here's the difference with specialty care. In specialty care, they're coming in for that thing. In primary care, they didn't come in for that thing per se. They may have seen the physician. Maybe the couple happens to be there together for one of them is having a visit and something comes up during the visit. And then the PCP is like, oh boy, it looks like you could use some support here. And then introduces me as the clinician into the room to work with them. So that's one scenario. And then the other scenario is that sometimes I will walk into a situation. Let's say I'm working with the referral, the handoff is for the female with depression. The husband is there. And as we start talking, it becomes clear that relationship dynamics come into play. So like the challenge there is quickly understanding my role in the room and orienting and making a decision in terms of how I'm going to position myself with them and what kind of issues I'm going to attack today. So I think that piece of work is really, really important to do. So the take homes I would say there are sort of start as you're doing your case conceptualization in your head, you have to start defining your own role, right? What is it that I'm doing here and what can I accomplish today, right? That's the other part, because you may think of a more expansive role down the road for future visits, but for today, what is my best role? And then communicating that effectively to them, right? So that they're also at play. Because remember, they didn't come in for this, right? They didn't come in for, a couple's intervention per se. And so being very clear with them about that is important. And in most cases, I kind of position myself as like, if I have like sort of quote unquote, the identified patient, which is not really a term we use in primary care much, but if I'm working with the person that the handoff was originally about, I will usually say explicitly, hey, so Dr. So-and-so has us working on your depression, but it's clear here that your relationship dynamics are an important part of what's feeding into the depression. Does that sound right to you? Does that sound like what's going on here? And then I'll turn to the partner and say, do you also agree that that's a big part of what's possibly happening here? So I get their agreement on that piece. And then I say, so it sounds like it might be important and helpful for us to work on the dynamic and the relationship, right? And we could work on potentially some communication and some strategies to help you all begin to kind of, we could pick a particular behavior or whatever, right? So what I'm trying to do there is define my role, but I'm also trying to get agreement from them. And it's a form of informed consent as well, right? Because they need to be on the same page. I can't do an intervention if they're not willing and don't want to, have that intervention occur. So yeah, so that to me is the most important part initially of working through these sorts of situations.
Yeah, I would agree. I think on the physician side, what first comes to mind with couples is like we get drilled into our heads the HIPAA and the privacy and the confidentiality and who's signed the ROI that you're allowed to speak on anything with anyone other than the identified patient. So I think there's an unlearning process that we need to do in primary care to do what Bridget has always talked about, contextual, right? Interview. And I mean, just in the last year, I've been doing more of the who lives at home with you? What do you do for fun? Like doing some of that. And darned if it doesn't help, like to really understand, like, oh, okay, we can talk about sertraline all day long, but you're in a relationship that's unhealthy and that's your main stressor. You're in crisis mode. Okay, maybe we need to start there. So that's been a huge game changer for me. And so I guess navigating that more in the exam room with, an invitation, would you like to bring your partner to a visit? Would it be okay if we included them? Can we, loop them in? Happy to chat with them on the phone. I mean, that takes more time. So the busy PCP would probably hear me saying that and be like, well, I don't have time for that. I don't have time to call somebody's spouse after the fact. But I think it's, just the focus of whole person care of like, well, that might be what we need to do. And hence why we need teammates, right? Because if we have other people on the team to, carry that load and help us figure all that out and work together, then it can be a much more meaningful visit. So hurrah for the contextual interview. Go, Bridget, go.
Yeah, definitely. Definitely. Amen to that. And I would agree with the organic nature of, that we've all talked about, that the most common scenario for when I'm working with couples or doing some type of couples work or just kind of relationship work, which might be with the individual, the most common way is I'm working with the individual, and during the contextual interview, it continues to come up. And then, you start working on some stuff and it becomes very obvious to you and the patient that the person who is closest to them, the person who they live with, that this is causing a huge difficulty. And then it normally kind of falls into like, just throwing this out there, would you be open to having them come in so that we can kind of loop them in and maybe work on something or get their agreement? And so that does a lot of help for that informed consent process for like, well, what are we actually going to do here? And if and you're able to say, like, if it's just you and the individual and they agree to have the patient come in, you say, listen, still your BHC, and you make the decision about how much you want them to come in or not. And then depending on the context of the situation, then I would throw out if we're going to do something that looks a little bit more formal, or if this is just looping the partner in with the individual. So kind of, I know that's not very clear. It really does depend. Like it depends greatly. And some of the questions that I'm constantly asking before like working on stuff is this a relationship that you want to work? I know that sounds obvious, but anybody who's Grace is like, definitely not obvious. That's definitely something y'all are taught, right? Like, do you want this relationship to work? Because if you don't, we have a different conversation. We have a different route. And are you all in on this is really important to figure out. And then I'm constantly going for the lowest of low hanging fruit, where I'm trying to get the couple to have different relational frames with one another. Mm-hmm. So low hanging fruit, I do this with kids too. My go-to always is one-on-one time, because almost always the couple at that point has stopped having any fun together. So every association that they have with one another is problem focused and negative. And so I try to find out if there's something they used to do for fun, some level of getting where they can literally have joy with one another. And so that's normally skill wise where I'm going to first. The other area that I'm constantly going to, if both parties say they want the relationship to work, is just constantly bringing it back to both parties you guys want this to work, and try to reinterpret each other's behaviors in a different way. That maybe it's a trauma response. Maybe they're responding to something different. If that's the case, that when somebody's snappy, is that really towards you, or are they maybe struggling with something? So that's what I'm trying to break down, is just those like behaviorally negative interactions, and then the assumptions, giving grace to your partner again, and then having something where you keep coming back to, like, we both agreed this is what we want from the relationship. Mm-hmm. It's a little bit, it's a little bit obtuse what I just went over, because it really depends on the information that the couple is giving you.
Yeah, it's not obtuse at all, Bridget. You did a great job of explaining that. And there's a couple of like fundamental principles there that I just want to point out to people who are listening, especially early clinicians, because you made 2 points that are super crucial for clinical work in general, but PCBH in particular. So one key concept in psychotherapeutic work of any kind is alignment. So the alignment of the patient or couple in this case and the clinician, research shows that that's really one of the best predictors of whether that patient's going to get better. So like when I think about like outcome measures and things like that, I often encourage people to use alignment measures. Like, does the patient feel like you're listening to them and working on something that's important to them, right? So if you do a good contextual interview, guess what? You're going to have alignment because they're going to feel like you understand them and that you're working on the right thing. And with a couple, that's particularly tricky because you have two people who are potentially thinking differently about what the right thing to work on is. So that's why alignment is important, because you're not just creating alignment with the one, you're creating alignment with the two. And you've got to create that sense of alignment there. Otherwise, you're not going to make progress. And the research tells us you're not going to have a good outcome, right? So that's principle number one. The other thing that you pointed out that is a core PCBH principle is positive momentum. You always want to be, and this is especially important for couples, because couples typically, once they get to the point where they're seeing a helping professional, are entrenched in a bunch of behaviors that are counterproductive and in feedback loops that are really, really negative and difficult. So when you talk about low-hanging fruit, like the one-on-one time, like, you know, maybe a different communication strategy or whatever, you need to show that couple that you can actually create some positive momentum towards a better sort of way of working together, or they're just going to go revert back to those feedback loops after the session, or they're just going to disbelieve that you can help them. And again, when you think about the research on therapy outcomes, what's one of the other things other than alignment? What are one of the other things that predicts whether someone's going to get better? It's hope. They need hope. And for couples especially, getting that hope in that first visit is super huge. So you need that positive momentum. You need something that's going to unstuck them just enough where they walk out feeling like, okay, I think we might have a shot here.
And I would just want to jump on real quick. I promise this really quick. That hope piece, when you as a clinician are able to stay calm and be able to put what they're experiencing into context and saying, I see where you're coming from because from your lens, X, Y, and Z, and from your lens, X, Y, and Z, and you both want what's best. Like I totally am sitting here and being like, you're right and you're right. When they see me calm and like that I get it, and not that I get all of it, but I get it, they have hope. Like, oh, she's seen this before. Like, this isn't like I'm so especially effed up or we are so especially far gone. And I think that staying calm, and Kelly Wilson talks about in the ACT literature, that your reactions to what's going on is what you want to model their internal dialogue to be about themselves and the situation. So when I'm calm and just like, okay, this breaking it down, that's how you want them to model their internal thoughts instead of just going to the catastrophizing. Sorry, go ahead, Grace, because you're the expert on this part.
Well, I was just going to say, I think this brings to mind for me some of what we talk about as the really unique role of integrated care, of kind of going to where the people are. You know, we're taking behavioral health to the place where the patients are. And so you started out by saying, Naftali, most people aren't coming in for this. They're not coming in asking for it. And so that is part of that piece of why we want to come alongside quickly and to come alongside supportively, because a lot of times if patients are only ever going to go see their doctor for their problem, and then their doctor refers them to this behavioral health consultant, which part of the reason why we use that language is because therapist is too scary, you know, for people who weren't asking for therapy, just honestly. So we need to be challenging misconceptions and providing that support. And sometimes the role of that integrated care does not become, you know, we talk about this all the time too, to fix all of the problems. And especially with couples, and that dynamic gets very complicated, and there are very specialized forms of couples treatment. Integrated care and the work that we're doing in integrated care is not going to be a replacement for that specialty care for the couples that need it, but it can help with reducing the number of people that need specialty care because we're catching things earlier, we're intervening, we're doing prevention, we're filtering the right people to that specialty care, just like with pain management, just like with, rheumatology, just like with all these other specialties, we're filtering the right people to those specialists because we're taking care of what we can do in integrated care or in primary care, which I recognize not all of our listeners are in primary care, but just go with me for a second. And then we're also challenging misconceptions about what therapy can be or what behavioral treatment can be. And so all of those things are good. And I say that because I can hear some people in the back of my mind listening to this episode going, okay, but like this couple needs so much more than 8 sessions. This couple needs so much more than brief treatment. And like a lot of them do, sure. But maybe they're never going to go to a couples therapist, or maybe they need us to be a bridge to that, or maybe they need to start along this path, or maybe we catch some people sooner and so that they don't ever need that long outcome. So I think we're not saying that this is anything more than it is, which is a fantastic treatment for many, many people. But I felt like I needed to say that to put some context around what we're talking about and the role of this service.
I was talking with one of my mentors and he was explaining, he's like, us in the mental health field, we have all been trained to be especially not helpful. Like we figure out all the most convoluted ways to have convoluted informed consent, convoluted systems, and everything that is set up is like all the ways in which, I can't help with this and this and this and this and this. Like we are especially like unhelpful. The thing that I learned from PCPs, and they have their own challenges, right? PCPs, y'all have your own challenges, is they're infinitely helpful. Like at baseline, like a PCP, now there's, like I said, there's pendulum. If you think that you're helpful for everything and you don't get a specialized, enough training, that could be its own issue. But it's just interesting how, if you look at how, especially mental health, and I was trained that way, it's just like barrier after barrier after barrier. And if you get it in your head that my job is in this moment to be helpful to this human, and you trust the skill set that you've been training with for years, and you go all in on being helpful, it is amazing what you can find out. So instead of it being like, well, this isn't enough, this isn't what they need, maybe they need something else, what is this possibly going to do? Just, this is going to be too much because I'm in integrated care and it's 30 minutes and a couples work has to be 50 minutes and blah, 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 blah. And you're going through all the ways in which you're not going to help the person in front of you. If you start recognizing that you're doing that, which we were all trained to do that. So newbies, you probably are in that space. Start practicing challenging yourself. And before you go into the visit, you just reframe it and say, when I go into that room, I am going to join with this patient, like you guys said, align with this patient, learn about their life and what they want, and help them. I know it sounds too simple, but like maybe it is. Like there isn't.
That's exactly what I was going to say, Bridget, because you're talking about, Grace, you're talking about couples work being complex. I don't think in most cases it's actually complex. What it is emotionally tense. It is an emotionally tense, fraught situation. That doesn't equate to complexity per se. It really equates to discomfort. And there is potentially more content involved, right? But it's really just two people who are trying to make a life together. And they're bringing their tensions. And that tension comes into the room. And yes, that feels very different to us as clinicians. That feels tough. And it feels, we often use the word complicated, but it's actually it feels more heavy and more fraught with like consequences. So I would equate it to the work that I do between parents and their children. Again, it's not usually complex. We're talking about like setting boundaries, having structure and schedule, good communication, right? But it is fraught with emotional energy. And that emotional energy does something to our brains as clinicians that, we have to recognize, like it's there, it's real. Like I feel it when I'm in the room with a couple, I feel it. But sometimes I think as new clinicians, we can get a little bit lost and think, oh, that's complexity, instead of really engaging and saying, that's not really complexity. That's just like it's negative emotion at an intensity that scares me a little bit, right? And
That's
I'm
such
a
a
little
good
scared of the
point.
consequences
Yeah.
of what might happen if I try to help,
Yeah.
right? And it's okay to expect. I feel that as an experienced clinician, I still feel that every time I'm in one of these situations. But the experience just helps me to do what Bridget said, is just engage instead of disengage, and settle myself, try to figure out what's going on, how I can be helpful. And to your point, Grace, I also don't overpromise, right? I'm not gonna start off saying I can help you with everything you've got going on in your life, but I don't do that with individuals either. I don't think
I
I
want
have.
to I want to make sure that we do spend some time talking about like content and what comes up and what kinds of things can people address with couples. Because especially because there's one thing that I really want to emphasize is there's something that we do very well in integrated care is understanding this biopsychosocial spiritual interaction of constructs. And I think our patients don't think about it, and we don't even always think about the ways that that can be helpful. I saw a study the other day that came out where they were looking at CPAP treatment and couples satisfaction and conflict. And they had an intervention, not just for the individual who had the apnea and had the CPAP, but also from both partners. How were they reporting the changes in their relationship satisfaction and relationship conflict, and the improvement that the people experienced from CPAP therapy? But here's the thing. By the time someone gets to the point that they've had and been on the CPAP therapy, what's been going on in their relationship for how long, ever long this apnea has been developing and stewing and interrupting the sleep of, sometimes they call the partner of the person with sleep apnea like the invisible second patient, because their sleep's constantly being interrupted. And then what does that do to like their grumpiness with each other and their sex life? And there's so much that goes into it. And so I think sometimes we just need to take one step back and ask a question and say, hey, you've been snoring a lot. How's that been for your marriage? Or like, what's your sleeping arrangement these days? And how have you seen a change in that? And how are you talking about problem solving this? And so, that's one example, but there's so many medical, and I'll put quotations again, because we know that, we're making these arbitrary distinctions. But there's so many things that are kind of biomedical, traditionally considered problems that have the impact on the relationship. And so even asking a question of, what's this been like for you, wife sitting over there, as I'm diagnosing your husband with this, 20 years of sleep apnea and snoring. How are you guys managing this? Can go such a long way towards opening and facilitating this conversation. And I'm curious, Jen, if there's certain things that come up that you see a lot with your patients that seem to impact not just the patient, but the system.
Yeah, absolutely. Sleep apnea is a big one. That's like a commonly shot down, like, hey, how about a sleep study? And it's like, like, no, but there's ways to make it more patient centered. And you get why they'd say no, like, hey, do you want to go sleep in this artificial lab with all these wires and pretend it's an actual, in context night sleep? So like home sleep studies, I get people more like, okay, I can live with putting the, device on my finger and sleep in my own bed and get more meaningful data out of that. So yes, I think patient centered diagnostics is so important. Substances come to mind though when you're talking about impact on couples, right? That's a huge one in primary care that not a lot of PCPs had a lot of good training in having a conversation, because again, biopsychosocial comes in so much with substances and the spectrum of use and misuse all the way to use disorder. It's complicated, but very much can affect relationships and have downstream effects. So yeah, there's lots of examples of that where, the patient identified in front of us and their medical conditions, biopsychosocial context, all of that absolutely affects the family system, the spouse, the child parent, dyad, those things as well. So yeah, it does not exist in a vacuum.
I even think of the big umbrella of chronic illness, right? And, especially some of the illnesses that are, they have they get a little better and then they get a little worse. And then you never know how a day is going to be. Things like fibromyalgia, things like, the relapsing remitting MS or other conditions that sort of come and go, and the impact that that has on the uncertainty in the family, or the other partner having to step up and take care of responsibilities that maybe they had shared before, but now this one partner is experiencing this chronic illness. And how does that change the dynamic in their household, or change the attention for both of them? And we're talking about couples today, but I think, you made the analogy of parents and kids earlier, Naftali. One of the reasons why I ever was interested just from in being in this field at all is, as a kid or a teenager, I was like, what's happening to the siblings of sick kids? When we have kids that have a severe or chronic or terminal illness and their sibling is fine, air quotes here for those that are listening, and doesn't have these health problems, what's happening to them? And thinking about these family systems. And that's true in couples too. You have the one person who's the patient, and everything in life has to be organized around that illness sometimes, just to get through it. And so what happens to the other partner? What happens to the relationship in the meantime?
I'll throw one more. Those are great examples, but I'll throw one more that is more very personal to me right now, is menopause. So, my wife is perimenopausal, and it's had an impact on all of us. And I was just swimming at the pool the other day and having to start a conversation with a woman swimming in the lane with me. And she was saying, she just sort of randomly started talking to me about like some symptoms she was having. She's like, yeah, I'm menopausal, and working with my provider and trying to figure out what to do. And she was like, it's really, really hard. Like I wasn't prepared for this at this age, and how it's impacting not just me, but my partner. And it is pretty significant. And the way it would present in primary care is interesting, because if you're not contextually driven, you could easily just sort of, think of the individual and just be like, okay, well, we'll work on your symptoms, your headaches, your fatigue, all that kind of thing, and not really consider like, oh, so how's this really affecting the key supports and relationships in your life? Because if you think about it, what can happen with a perimenopausal individual is that they can experience bouts of depression and then and diminished libido. So let's just take those two as particular symptoms. Then that's affecting their relationship, their main support relationship. Now, let's say that relationship then deteriorates as a result. Then you've got like worsened depression, right? And probably increased somatization of just even that, right? Coming into play. So really, like, it should be almost protocol, I think, now having gone through this experience with my wife, that if you're working with a perimenopausal woman, like, you should at least ask, how is this impacting your key relationships? And then say, hey, would it be helpful if we invite your partner here to have a conversation about what perimenopause is, what to expect, what treatment looks like, how you can be supportive, at just a baseline thing. That should just be just baseline stuff. What I've found is through this process is that, and Jen, I'm curious to hear your perspective on this, but it doesn't sound to me like there's a whole lot of training around perimenopause and how to manage it effectively, and kind of all of these other contextual factors that we're talking about. Is that, you tell me.
Spot on. Absolutely. I'm trying to think back, like, did I ever get formal training on how to address perimenopause? No, I can't think of any. It was a lot of like, what does Up to Date say? I don't know, gabapentin for hot flashes. That's not good enough, or, oh, go talk to your gynae, right? We're primary care. Maybe your female specialist has something meaningful to say on that. And that is a very unpleasant and almost traumatic experience for the patient seeking help, to almost feel like they're being gaslighted and like, that's not a thing. saying your symptoms are just, you're depressed, or, it's like, no, like it's real. And yes, many women have had that experience, and it's a shame, because the last thing you want is to put yourself out there vulnerably with, hey, I'm having these symptoms, and your medical provider to have like, well, I don't know what to do for you, or, oh, that's not real. So yes, absolutely. I think that's a knowledge gap for sure. And I don't have any good answers on that. I think we target symptoms, but I think, bringing back to Bridget's point, the goal of visit, maybe it's just to be helpful. Maybe it's just to say, yes, this is a real thing. You're not crazy. You're not making this up, as a goal for the visit. Like, I don't have all the answers. Science has a lot more research to do in this field, but at least if we can align on, I'm acknowledging you, I see you, I hear you, like, I think that helps. It's a place to start anyway, that you feel like you have a trusted provider that can at least get in there and listen during those tough times.
Just speaking as a patient, I would have loved to. So in my wife's own story, and this is not TMI, she'd be fine with me sharing this, but in my wife's own story, it took us about 1.5 years to figure stuff out. It took a long time, and I would have loved as a patient to be invited, like, and in our case, in our situation, there's like literally one OB-GYN in the community that everybody refers these situations to, like one. And then the funny thing is, to your point, Bridget, and this is a parallel between medicine and behavioral health. Sometimes we overcomplicate things, right? Like the actual treatment pathways are not complicated. You don't actually need an OB-GYN to kind of be managing this. You just really need a little bit of like
Correct.
knowledge around like what the options are, right?
Yep.
And so like you can do, a hormone therapy, for example. PCP can do that. That's not, out of this world, right? You can do antidepressant therapy in some situations, So that's the funny thing about it,
I want to capture something you just said, Naftali, because it echoes what we said in our last podcast about couples. You don't have to be an expert on all of these issues. You have to know a little bit to be able to ask the right questions, to be able to know when something's not normal and needs to be maybe escalated, or to bring someone else in on the team. But, Bridget put in we're talking about menopause. Bridget put in the chat pregnancy. Issues of infertility oftentimes are very couple bound. Partners making decisions about caring for a partner who is developing dementia, and the ways that changes the role and the dynamics in the relationship. Becoming caregivers, becoming a caregiver to a spouse who has a chronic illness in a different kind of way. I mean, we can rattle off all of these. You mentioned in our last podcast, Naftali, just the change of life, of the developmental stage of your kids growing up and getting ready to leave, and then empty nest and the role that has. And so we don't have to know everything about all of these things. We need to know a little bit. We need to be able to ask questions. We need to know what's most common so that we can connect with our patients quickly and instill that hope, so that we're not the deer in the headlights of, oh God, everyone in this room can tell that I've never heard these words before. That's never what we want to communicate. But to know a little bit, enough to start the conversation, enough to lay this on top of our really solid foundation of all of the other things that we've been talking about, of the contextual illness, of understanding, or contextual interview, of understanding chronic illness, of working with families, of biopsychosocial spiritual, of all of the things that we know to do in our wonderful collaborative treatment. But we do need to know a little bit.
Yeah, I think if there's a take-home message, is just the organic. I mean, that was beautiful. As Grace has the best summaries ever. It's an LMFT training. It's amazing. I love it so much. It's just that when you enter people's world and you see things from their lens, and you sell out and go all out on what is actually happening in this person's life, and you kind of, instead of being symptom obsessed or diagnostically obsessed, but you become obsessed with what is the experience of the patient, they're going to tell you, and that's going to become apparent, all the ways in which, and then all the other things you said about being biopsychosocially minded, you're going to start hearing and seeing it. And so I would urge folks to not get too caught up, and I probably said this the last time in the couples, but I'll say it again, to not get too caught up in like, I'm doing individual work. This is a couples therapy appointment, and just let it be a little bit more organic, and to not freak yourself out. And then what you all had said about 1 degree shifts and all of that. And people give you a lot of credit, even if you don't content wise knows something, you could go and look it up by just being endlessly curious. They give you a lot of credit for showing up and wanting to know. People don't give you credit when they feel that you're shutting them down, but you get credit for wanting to know. And it's not an excuse to not know anything. You got to go look it up or like get involved in some trainings if there's an area that you're like, oh, this keeps coming up. But patients, they don't expect in most cases you to have all of the answers, but they do expect you to be endlessly curious about it.
And I think the only other thing I would add to that excellent set of points there, Bridget, is also don't let time be your enemy. In other words, the other key barrier I hear and feel sometimes is like, oh my goodness, this is going to take more time for me to kind of do whatever it is you've decided in the algorithm of things to do, right? And it's like, no, just like, enter in with that curiosity, acknowledge the time, right? I mean, you're in primary care, you have to be aware, right, of the room you're in, what kind of time and space you have, but use the time you have instead of seeing it as a limiting factor. Like, use it, do something with it. That will naturally and organically inform what you might do next at a future visit. And then you use that time, right? So you think of it positively. Think of it in terms of like, I've got this time. And if it's 15 minutes, if it's 10 minutes, that's the way I approach it. I've got 10 minutes. What can I do? How can I be helpful? Right? That framework is important, because otherwise we with couples in particular, we tend to think of like, it's going to take this and then I'm going to get behind, and and that applies to PCPs and BHCs, care managers, all the folks doing this work. Like, just think of time in a positive sense. Do what you can with it. Don't think about how you're limited by it.
Love that. Any last thoughts anybody wants to share as we're wrapping up our conversation about couples? I think my parting thought is that we can do this work, and it's not so different than anything else. And I would love to hear, we have our active listserv. It'd be fun to hear how people are finding their way through working with couples. And yeah, so I'm thankful to all of you for joining me today. I'm thankful to our listeners for tuning in, and we will talk to you next month.